Thank you, sir.
To talk on relook at stem cell therapy in wound healing.
Well, thank you very much for having me here in Chennai. Thanks, Rajesh. Thanks, Dr. Murthy. It's excellent to be here. I must say I'm really, really happy to see so many faces in the audience even at this time. This is going to be a little different because we've been listening to wound care since morning. Now we are going to relook at stem cells and its role in wound healing. At the onset, I'd like to tell you that there are no such clinical trials where they are just trying to see if stem cells are just working on wound care. All trials have come into existence because we have just realized from 1800 that stem cells have quite a lot of potential in them. So basically, stem cells have started to be noticed as playing a role in wound healing by virtue of other clinical conditions that they are trying to be treated. So we'll start why stem cells have a role in wound healing. Basically, we were trying to treat critical limb ischemia. And as you all know, that critical limb ischemia is the end stage of peripheral arterial disease, and it is involving characteristic features of rest pain, ulcers, and a significant risk for limb loss. Now, approximately 40% of these patients cannot be revascularized. So we have to look for alternative options so that we can salvage their limb. Current treatment which is available is revascularization, surgical or endovascular, and only 20 to 30% of CLI patients qualify, and the others just don't. We have medical therapy with prostaglandin analogs or cilastazole, but not everybody responds to these modalities. So what do we do next? Now we really have to sit and think, and that's where we started to deploy stem cells to look at them as a novel technique for helping us salvage the limbs and indirectly helping us in wound closure. So the protocol for treatment remains the same. We advise the patients to have a risk factor modification. We advise medical management. We give them endovascular or surgical option if available. And if nothing, we turn around for stem cell help. Now, the question is, can stem cells actually help us? From 1800 till date, we all have come to this conclusion that actually the stem cells, because of their capacity to renew and generate differentiated cells, can help us in arteriogenesis and indirectly increase vascularity of the limb and in another way help us in wound closure. Now, I'm not going to elaborate on the types of stem cells which are available because all the trials which have gone in, almost 1900 trials have gone into stem cells so far. Each and every interested scientist has gone ahead and made use of the facilities available to them. I'd say the breakthrough started in 1997 when Usher et al. Identified a class of bone marrow-derived circulating endothelial progenitor cells, and he contributed to literature by saying that yes, they can cause angiogenesis or vasculogenesis in ischemic tissues. What is interesting is in all these trials, they had the same parameters to judge. They all noticed that there is an increase in TCPO2, there is improvement in laser Doppler flowmetry, there was pain reduction, there was a larger pain-free total walking distance, and best was that there was decreased rate of amputation. And if you noticed, sorry, I ran through the slide, and if you noticed, the ulcer healing is at the bottom of the slide because this parameter was actually assessed indirectly. There wasn't any trial talking about the role of stem cell in ulcer healing. Then came the TAC study, which started in 2003 till 2009, which was essentially a study which compared the efficacy of bone marrow mononuclear cell to peripheral bone marrow mononuclear cells. And as you can see, there were 22 patients. And out of those 22 patients, half of them were injected with peripheral blood mononuclear cells, and half of them were injected with the bone marrow-derived peripheral nuclear cells. And the conclusion was that the bone marrow-derived cells were more efficacious than the ones which were from peripheral blood. Then there was another trial which showed us that if there was a granulocyte colony stimulating factor, the number of cells that were mobilized from peripheral blood were larger, but there was no significant difference between the two groups, whether it was pain-free walking interval, or there was TCPO2, or ulcer healing, or even the rate of lower limb amputations. There's another interesting study. By all this time, a lot of investigators had jumped in, and they started to compare whether an autologous bone marrow stem cells and peripheral bone marrow stem cells were equal, or which of the two were better efficacious. Finally, the conclusion came out that bone marrow stem cells and peripheral blood stem cells are both effective in critical limb ischemia. Basically, a retrospective analysis was done of literature in which almost close to 2,000 patients were enrolled. 303 diabetic patients with CLI and foot ulcers were included in the trial, and route of administration was variable. Some were given intramuscular injections, some were given intraarterial, some were given a mix of both. And the results all were very promising. They all showed improved functional outcomes, increase in ABI, TCPO2, symptomatic pain relief, promotion of amputation-free survival, and of course, complete wound healing in just 3 months. That's very interesting. We were talking about 12 weeks since morning, and actually with stem cells, there were certain studies which actually brought us to a conclusion that we can actually just bridge the gap between normal wound closure in ischemic limbs by using stem cells to generate arteriogenesis. Now I'm going to talk about the Indian experiences. I guess a lot has been written in literature, and since we come from an Indian background, we want to see what our colleagues are doing so far. Now this is a study which happened at my center. We actually took 44 patients, alternatively subjected them to a transplant group and the other one to a control group where we just medically managed them. They were all Burgess, and they were all followed up for 6 months and DSA at 1 year. And the primary endpoint was very simple. We just wanted to see whether we could prevent amputation or not. So we injected, granulocyte colony stimulating factor for 5 days till we got a good CD34 count on cytoflowmetry. And then we created a cell suspension and injected them to our transplant group. The patients were then followed up, and at 6 months, as you can see, both the groups, whether it was transplant or it was a control group, the change in, or let's say the increase in pre and post ABI or laser Doppler perfusion or TCPO2 was better in the transplant group. And the ulcer healing was for 18 patients out of 22, whereas only 5 healed in the normal control group. And look at this. The major amputation was none in the transplant group, whereas there were 4 in the control group. That's a DSA evaluation at 1 year, and as you can see, there is a lot of collaterals which have come up. We can actually see a dense tree of collaterals which have come up in response to the transplant that we had done. These results were quite inspiring, and actually in Outlook, they have been published in 2007 as a use of peripheral blood mononuclear cell autologous transplantation can prevent amputation, which is looking like a viable therapeutic option to us. Now, we have a very interesting investigation published by one of our colleagues at AIIMS, Dr. Sharma, who actually went up and did a pilot study to see about the cell concentration in these suspensions. He divided it into 2 groups, control and then intervention group, which has different strengths of cell suspension. And he actually came up that no matter what dosage of cells you put in, there is not going to be an influence in the outcome, whether it's good or bad. This is very interesting because later on, people are now questioning as to how many cells need to be injected if you want a good outcome. This is another interesting Indian experience, which is by AIIMS again, and there were around 53 patients in this study, and they were all followed up for 6 months. This is a 1-to-1 randomization group study, and in this group, apart from the medical management, the cilostazol and the aspirin, the treatment group was also injected with autologous bone marrow-derived stem cells. The interesting part about this study is that for even this study, when they did a DSA, they see that the dense arterial tree, which was coming up, was quite promising within 3 months. So I guess what we are looking at is there is no direct correlation between ulcer healing, but we know that since vascular deficit can delay wound healing, we have to find novel techniques of substituting vascularity in this patient, and directly that's the role of stem cells. Dr. Ravi had a very interesting conversation, I think, in one of his presentation talking about PRPs, and I still have to experience that. But we at our center is essentially looking at stem cells as a novel technique to increase vascularity for the wound bed so that the patient is even symptomatically better. There should be pain relief, there should be increase in parameters which indicate that yes, there is sufficient blood flow to the wound bed so that it can close. This is one of the research papers that has been printed by my chairman, Dr. Rajiv Parekh in Delhi. I'm one of the co-investigators on the study. It's already been published in Journal of Translational Medicine. And as you can see, even in this trial, this was actually a phase 1, phase 2 study. They were trying to evaluate if it is safe and efficacious to inject 2 million cells per body weight, and if they had some amount of role to play in pain-free walking distance or amputation-free survival. So, and again, as I said, TCPO2 and ABI increased. This is an ongoing study which I'm doing in my center currently, and I must say this study has not been so promising. We just had 4 patients on board, and out of the 2 that we enrolled, we lost them to follow-up because they weren't convinced with what was happening. But out of the 2 that remained, 1 had an amputation, and the other patient had an ulcer which dried and healed. So this particular trial, I can't mention the sponsor's name, but I still feel that, it's not always a glossy ride with stem cells. We are still very much under the learning curve, so to speak. Now, there is a southern experience here down south with the Sri Ramachandra University here in Chennai itself, and I think very interesting study, so I brought it up in my presentation. Total number of patients are around 60 and 30 subjected to the intramuscular group in the gastrocnemius muscle, and the other one injected with the SFA infusion right there where the occlusion is. Rutherford category, critical limb ischemia was 4 to 5, and they had just basic 3 parameters of ABI less than 4 and toe artery occlusion pressure less than 40 and TCPO less than 20. I think it's a really crisp study that they did. And they kept the same study endpoints about amputation-free survival, improved perfusion rate, pain-free walking distance, as I mentioned. And they used the Harvest technology, which is by LifeCell, which, according to their conclusion, is quite safe to use. There is significant improvement in all study endpoints. By study endpoints, I mean ABI, TCPO2, pain-free walking distance, amputation-free survival. And there was a limb salvage rate of 83.4%. Isn't that really, that's really promising, very encouraging. And they found that there was no difference if they gave an intra-arterial injection or an intramuscular injection. Now, we are still at Medanta trying to work our way with the Harvest machine, because we now call it BMAC arrives at Medanta, because we wanted a quick, effective method of separating these stem cells and injecting them in a quick OT out time of 40 minutes at our center, which is very well provided with this new technology. And we are just studying the effects of bone marrow-derived mononuclear cells in ischemic limbs and its role in wound closure. Now, I have started to map this just out of curiosity, because I run a center of wound care, and I want to see whether actually stem cells did play a role, because all this while people are regularly doing DSA and MRIs to see if collaterals have developed, if we did get a dense arterial tree. People are not looking at stem cells from the aspect of just wound closure. They are actually more interested in seeing if there is an increase in vascularity, which is indirectly causing wound closure. So far, we just started in March. It's a baby. We are still teething. We are still learning. And there are about 8 subjects we have enrolled. Our plans is to keep it going till 1 year. And we have only included subjects. We can't reconstruct on the Zigo lab because we are a vascular unit. And we make sure that there is diagnosis of critical limb ischemia. We've included 4, 5, and even 6 so that we can level out the level of amputation if at all required. We are looking at non-healing wounds, more than 3 months duration, non-responders. We have used visual analog pain scale because I understand that patients have a lot of pain. CLI patients actually come to the hospital when they have pain, not because their wound is not healing. And of course, the patient should have at least ABI of less than 5 and a TCPO2 of less than 40 to be a part of our study at Medanta. Our endpoints are fairly simple. We want to see how many limbs we saved. Did we actually increase perfusion? If the visual analog scale actually went down, did the pain-free interval actually increase? And we have a unique tool at the center called SPY transcutaneous angiography, by the way, which actually shows us cutaneous perfusion. Safety of BMAC is still analyzed, and we also fill in the quality of life questionnaire to see whether after the infusion of stem cell, how holistically the patients are responding to care. So the site of delivery is fairly simple. We do intramuscular and the gastrocnemius muscle, and we inject the cell buffer layer even in the peri-wound area. We manage wound with daily dressings and conservatively. Medical management is still continued. We haven't stopped our anticoagulation therapy. We are collecting data at every visit. As you can see, the collection is on. And so far, these are a few pictures that I like to say. That's an ischemic lung, a chronic smoker, looks like nice granulation tissues being coming up. That's another patient, ischemia. We see the wound bed is granulating, quite promising. We just 8 patients, we are still not there. So the results so far says that limb salvage, no amputation so far. 6 months down, we are happy. No, we're looking at a few toe amputations in the coming week, but no limb amputation. Perfusion rates are increasing. The visual analog scale score is becoming lesser. It's decreasing. Patients are very happy because they're symptomatically better. I said pain is an important criteria for management in CLI patients. SAs have happened. 2 of the wounds have got infected, and we will need amputation for these infected toes. We are filling in our questionnaires about quality of life, and we will evaluate them at the end of the study. BMAC is a safe technology. I mean, 40 minutes in and out OR time is excellent. With stem cells, it's very easy. We are using the word in and out stem cell, and this morning when we had our chief guest, and she was elaboratively talking about the various sources of stem cells and how people are just using it everywhere in every clinical practice. I say that there are certain issues and concerns also with it. There is no correlation so far in any of these studies since last 2 decades as to what is the clinical response and what was the cell number that the patients actually received. There is no correlation between the phenotype of cells. Somebody says the EPCs are better. Some say the mesenchymal stromal cells are better. Some like the adipose stem cells. So basically, there is no correlation between phenotype of stem cells and how efficacious are their neoangiogenesis. Nobody has that static picture in mind. If we answer the first 2 questions, we will be able to understand how many cells do we ideally need to obtain wound closure. There is no optimal delivery route. Few people like it peri-wound, few people like it intramuscular, few people like it intra-arterial. So nobody knows the route correctly. There is an intense cooperation between lab and clinical investigation. Some MRI reports are so deceptive. They will show you such great collaterals, and some would really be misnomers. You feel nothing happened in the last 6 months. So what we need is a single uniform step all across the country, all across the globe, to centrifuge stem cells, to have a perfect count of cell numbers which should get injected, so that we can give a randomized control trial everywhere and see if yes, all populations and all patients are responding in the same orderly manner. I like to conclude by saying that we need RCTs more, of course. We need optimal selection of cell types. We need to know what cell types we need to use. We should know what isolation method we should use. We should know what cell numbers we want. What is the role of colony stimulating factor? I mean, I still don't understand why we inject so much of Neupogen to increase CD34 counts. The route of administration is still so unclear. People are challenging paracrine stimulating mechanism for the real cause of stem cell. So there are so many questions hovering around stem cell therapy, and just by re-looking at them during wound care is not justice to the amount of potentials these cells have. So I'll say there is future for stem cells. There is, of course, a lot of future for stem cells, but qualitatively the product should be better. There should be combined routes of administration. Like I said, you can inject them peri-wound or intra-arterially or intramuscularly. Whether we should have higher doses or multiple injections. Can we combine gene and cell therapy together and see how that works? And of course, if we start stem cells at the earlier stages of the disease, will that be a better protocol to do? And I like to bring this that application of imaging technologies is very, very important. I mean, how does one know how the engrafting or the homing or the placement of these stem cells actually take place? We have no imaging studies to guide us for tracking the location, engraftment, and survival and administration of these cell types. We are just performing n numbers of studies on different type of stem cells without having any conclusive data. So in the end, I'd like to conclude by saying that though we are relooking at stem cells, I have relooked almost close to every literature that's possible from the early 90s till 2015. And all I've come to on a conclusion is that yes, there are tits and bits scattered, and no one's actually looking at stem cell for wound closure. It's an indirect parameter which is being judged by the amount of the increased vascularity. So we need trials. We still need a lot of trial to come to a conclusion, because I myself as a speaker would say we don't know what is the ideal route, and I certainly don't know what is the right kind of cell type you would like to use. It really, really depends upon the facility you have in your institute. We are using autologous bone marrow because Harvest has come up with this new technique and we can centrifuge it in the OR. So a lot of questions. With that amount of questions, you can't be conclusive about the kind of cell therapy which is going to give you optimal results for wound closure. We still have a long, long, long way to go. Thank you so much for your kind attention. And in the end, I'd like to invite you all. We are hosting our 5th Vedanta Comprehensive Vascular Intervention course, in which I run the diabetic foot module, revealing the secrets of diabetic foot management. And we talk about everything, vascularity. We talk about, we only do workshops. It doesn't have any lectures. We'll have patients. We show about dressings. We take you to the OR, we do debridements and so on and so forth, because it's a hands-on experience. So if anybody's interested, please reach out to me after the lectures are over. And thank you so much for the privilege of this podium.
Thank you, ma'am. Let us hope for better benefits out of the stem cell therapy
Yes, of
in
course.
the future.
Yes, of course. I hope, Rajesh, I was able to do justice to your topic when we started to talk about stem cells. And I think, as I said, there is a lot of question. There's a lot of dilemma as to where and how stem cells are actually going to take us as far as wound closure is concerned. Thank you so much.
Questions are invited.
Rajesh has a question.
Thank you.
Thank you so much.